Welcome friend to my series of lectures on acid-base homeostasis. In this series, I'll be helped along with a close friend of mine and a batchmate, Dr. Anand Shankar. Dr. Anand Shankar is an anesthesiologist and critical care medicine specialist. Together, we'll be discussing about the pathophysiology and the treatment of acid-base homeostasis. The topics I will be covering include the clinical presentation of acid-base disorders. I'll be discussing about the classification of acid-base disorders. We'll discuss about the various compensatory mechanisms that include the blood buffer systems, the bicarbonates, the hemoglobin, the protein, the phosphate buffers. I'll also be discussing about the renal and respiratory compensations. We'll discuss about how a sample should be collected for an arterial blood gas analysis and what are the pre-analytical errors that can affect the results. I'll also give you a basic algorithm of how to interpret an ABG report. Dr. Anand Shankar will take over from here and discuss the ABG reports in cases which have got multiple patterns or complex patterns, and then he will also discuss about the treatment of acid-base disorders and how the information of an ABG report and the pathophysiology of acid-base disorders guides them in treating people with acid-base disorders. So let's get to the first part of the presentation, and that would be the clinical presentation and classification of acid-base disorders. Usually, a person having acid-base disorders would either be found in the emergency or in the ICUs in altered sensorium, by and large. This is a classical presentation of a young child with a sudden onset loss of consciousness with deep sighing respiration. This is what we call Kussmaul's respiration. There's a fruity breath, a very high blood glucose, and there was evidence of dehydration. This is classically the presentation of a diabetic ketoacidosis. Here, the body's metabolism is producing a lot of acids, that are the ketone bodies, and it is these acids that are causing the decrease in the pH. So it is metabolism producing acids leading to acidosis, metabolic acidosis. On the other end of the spectrum is this small girl who was admonished for a mistake which she did, and then she started getting hysterical, hyperventilating, loss of consciousness, and she got into tetany. This is a classical case where hysteria led to hyperventilation. Hyperventilation led to washing out of carbon dioxide from the lungs. Now, the carbon dioxide, when it gets washed out from the lung, means that the carbonic acid levels in the blood decreases, and this leads to a condition called alkalosis. Here, it is alkalosis, which is produced because of respiration, hyperventilation, respiratory alkalosis. So, when we talk about the classification of acid-base disorders, we have acidosis on one end where the pH becomes less than 7.35, and alkalosis at the other end where the pH is more than 7.45. Acidosis or alkalosis could be created because of certain metabolic processes, or the lungs could be involved as the primary source for causing acidosis, alkalosis. So either you could have metabolic acidosis, which could be metabolic or respiratory. You could have alkalosis, which is metabolic or respiratory. Acidemia and alkalemia are two words used to define the pH obtained of the blood from an ABG analyzer. The conditions that lead to acidemia and alkalemia, the diseases that cause acidemia and alkalemia, are acidosis and alkalosis. So let's now dwell into metabolic acidosis and alkalosis. Metabolic acidosis can occur because of gain in acids or loss in base. There are a lot of acids which can be produced during the metabolic processes, as in methanol intoxicity, uremia, diabetic ketoacidosis. Here the ketone bodies are there, paraldehyde poisoning, iron therapy, lactic acidosis, ethanol toxicity, salicylates. All these results in gain in acids in the body. On the other hand, if a person is having loose stools and diarrheas, there could be loss of alkaline fluid from the gut, and when you decrease when you have a loss of bases, that results in the production of acidosis. Renal tubular acidosis is another complicated mechanism which results in the gain in the concept of developing acidosis. Now, it is not possible for a lab to check up all the acids which are producing by the various metabolic processes. It's time consuming and practically the menu is a very large one. Secondly, we need to know whether the acidosis is being produced because of gain in acids or loss in bases. These will be a primary condition which would dictate our management of the patients. To get this answer immediately, we have a concept of anion gap. Now, the formula for anion gap is sodium potassium minus chloride and bicarbonates. Now, there are a lot of unmeasured anions and a lot of unmeasured cations. Ideally, the sum of all the cations and the anions should be neutral. But we just measure these 4 ions and the rest are all the unmeasured anions and unmeasured cations. The difference of this usually remains static. So, if you are using the first formula, the anion gap is about 12 plus or minus 4 milliequivalents per liter, and if you are using the second formula, the value is 8.5 plus or minus 4 milliequivalents per liter. We should be very clear as to what is the formula we are using and what is the reference value of that. So, how does the anion gap help us in understanding our basic question, whether it was excess production of acids or decrease of bases? Now, if the body is producing acids, as a first line of defense, the bicarbonates present in the serum neutralize the excess hydrogen ions. So, the bicarbonate levels will decrease. If the bicarbonate levels decreases, then this anion gap will artifactually appear to be big, right? So, there are unmeasured anions of the acids being produced. We are not measuring that. The bicarbonates which are there is being used as and neutralized. So, what we actually get is a high anion gap. So, if you have a high anion gap, then you know that some acids are being produced. Normal anion gap acidosis, when there is loss of bicarbonates in the gut or the kidney, the reabsorption of chloride and sodium by the kidney increases. This results in gain of chlorides for electrical neutrality. You are losing bicarbonates, but you are reabsorbing chlorides for electrical neutrality, so the anion gap does not change. Renal tubular acidosis is a rather complex subject which will be taken in a separate lecture series, but there are 3 types of renal tubular acidosis. Type 1, where there is a distal convoluted tubule issue where the sodium hydrogen anti-transport mechanism is defective. Type 2 is a proximal convoluted tubule issue where the reclaiming of bicarbonates becomes defective, and type 4 is a condition where there is a response, where there is a decreased response of the distal convoluted tubules to aldosterone. Aldosterone is important for the body to reclaim sodium. When sodium is not being reclaimed, hydrogen ions and potassiums are not being lost on the anti-transport mechanism, as a result of which you have low sodium, high potassium and high hydrogen ion concentration. This leads to hyperkalemic metabolic acidosis. Metabolic alkalosis could be because of increased production or increased intake, and we have other 2 conditions, which is the chloride responsive and the chloride resistant alkalosis. Now, classic was the people with gastritis who used to take alkaline substances like antacids, digoxin, drink excess of it, and because you are taking too much of alkali into the system, you end up in metabolic alkalosis. With good treatment and proton pump blockers, this usually does not occur. Another condition where metabolic alkalosis commonly occurs is in patients get massive blood transfusion of 3 to 5 units of blood. The citrate, which is used as an anticoagulant, when it comes in the blood unit, gets metabolized in the TCA cycle to produce bicarbonates. So, there is an increase in the bicarbonates, and this leads to metabolic alkalosis. Chloride responsive and chloride resistant alkalosis. This is a figure which we understand by measuring the urinary chloride levels. Now, when there is hypovolemia which occurs because of prolonged vomiting or a nasogastric suction which is seen in intestinal obstruction, or when people are given loop diuretics, there is a decrease in the blood volume. The body will reabsorb all the sodium. Potassium hydrogen ions will be lost for the reabsorbed sodium. Bicarbonates and chlorides will also get reabsorbed. So, here you will find that the urinary chloride is less than 10 millimoles per liter. This is classical example of chloride responsive alkalosis. Now, chloride resistant alkalosis occurs when there is mineralocorticoid or glucocorticoid excess. It could be endogenous or it could be iatrogenic. Now, the glucocorticoids and mineralocorticoids induce the reabsorption of sodium, with potassium and hydrogen ion wasting. So you're losing potassium, you're losing hydrogen ions, so this is causing alkalosis. Since there is no depletion of volume, there is no effort to reabsorb the chlorides, so the urinary chlorides will be more than 20 millimoles per liter. This is chloride resistant alkalosis. Now let's get to the other end of the spectrum, the respiratory acidosis and respiratory alkalosis. The basic equation that which you all need to understand is carbon dioxide plus water gives carbonic acid. So if there is a condition in which the carbon dioxide levels in the blood increases, as in decreased respiration, increased carbon dioxide, increased carbonic acid, acidosis. On the other hand, if you hyperventilate and lose carbon dioxide, in effect you are losing carbonic acid, and loss of carbonic acid, loss of acids from the body leads to alkalosis. The presentation of the child in the first part of the lecture was classically metabolic respiratory alkalosis because of hyperventilation. The basic causes for respiratory acidosis include abnormal ventilator setting. When the ventilator setting is not good enough to clear off all the carbon dioxide being produced, the carbon dioxide gets accumulated in the blood, causes acidosis. Chest deformity, muscular dystrophy, severe asthmatic attacks, they could produce acidosis. The common cause of alkalosis include asthma, hysteria, high altitude. Hysteria, we explained it. High altitude, because the atmospheric oxygen is less, persons tend to hyperventilate, and when persons hyperventilate, you are losing carbon dioxide, and that's producing alkalosis. Asthma, features in alkalosis, features in acidosis. So which is correct? Both. An asthmatic patient usually takes rapid, shallow respirations. So there's excessive washout of carbon dioxide, and that causes a bit of alkalosis. So most of your asthmatic patients have an element of respiratory alkalosis. But if an asthmatic patient is showing a pattern of respiratory acidosis, it is a very severe asthmatic attack. It has its implications in patient management, which we'll cover subsequently. In the next lecture, I'll be talking about the various compensatory mechanisms which is present in the body, and then I'll take one of them, the buffer systems. We'll discuss the bicarbonate buffer system, we'll discuss the protein buffer system, we'll discuss the hemoglobin buffer system. Here I'll be talking about concepts of Bohr's effects, Haldane's effects, isohydric and chloride shift. So let's meet in the next lecture. Thank you.